Okay, guys, so in this section, we'll get into some classifications of heart failure, some terminology here. So, as we discussed, there are heart failure is a syndrome, right? And it could fall under two general umbrellas. So, we could either have impaired pumping performance or impaired relaxation or elevated filling pressures. And we describe these as either systolic heart failure or diastolic heart failure, or we may also use the term dysfunction. So, systolic heart failure is exactly kind of what it sounds like, right? It's impaired systole or impaired ability for the heart to contract, right? It's the most common type of heart failure, where the incidence is about 61 to 68%, and diastolic about 16 to 39%, depending on the survey or the analysis. So systolic heart failure, we typically see that lower ejection fraction. That's what systolic heart failure kind of is. Again, it's an impairment in systole. Now, on that same line, diastolic heart failure or diastolic dysfunction is impairment in diastole or relaxation. So patients with diastolic heart failure have impaired relaxation. This is where we have that elevated filling pressure, right? So we might not see as much change in pumping performance. It's that they're operating at a lower efficiency because the filling pressures are higher. There's impaired relaxation. Now, this is more common in females. Hypertension is a pretty common risk factor, though often patients with systolic heart failure have hypertension too. Now, the thing I want to stress, right, is that most patients, right, have a combination of the two, right? Because it's almost unavoidable. If we have impaired contractile function and we can't get blood out of the heart, right, we're going to hold on to more volume, and that's going to raise filling pressures and impair the relaxation of the heart. And eventually, if the heart gets, the relaxation and filling pressures are so high, right, we won't be able to pump out the same amount of volume, which will also impact systole and ejection fraction and all that. So they're usually a combination of the two, and we term or diagnose a patient according to which of these types impact their clinical status most substantially, right? So usually most patients have a combination of both systolic and diastolic dysfunction, and we classify them according to what impacts their clinical status the most. And usually the outcomes are fairly similar. Now, there are also left and right sided heart failure. Now, this also comes from our Cahalan text, so refer to this. We're not going to spend too much time on it, but remembering that left and right, we can have failure to either ventricle. Now, left ventricle or failure is where we're going to see primarily those changes, right, in perfusion downstream. So we're going to see issues with that orthopnea. Again, we talked about, right, if we lay flat, mediastinal shifting, raising backflow of fluid into the pulmonary vasculature, disrupting the alveolar-capillary interface. So we're going to see those pulmonary edema, impaired perfusion to muscles, right? Impaired exercise capacity and weakness, the enlarged heart. We may also hear that S3 gallop, remembering we have a stretched ventricle, S3 gallop, synonymous with ventricular failure. So we have all these symptoms here. Right ventricular failure, which can often result from pulmonary diseases or with pulmonary artery pressure is elevated. Remember, the right ventricle is not really super resilient. It's kind of thinner. The muscle's much thinner. And because it's supposed to be pumping against very low pressures, the pressure in the pulmonary artery, should be negligible. If that goes above 25 millimeters of mercury, what we'd have in pulmonary hypertension, we can end up causing the ventricle to fail because the right ventricle just does not tolerate, does not accommodate well to elevations in pressure. When that happens, right, when the right ventricle fails, so again, that's just one example. There can be a lot of other causes of it, but pulmonary issues, pulmonary vascular issues are common causes. When that happens, the backflow goes, again, upstream. But what's upstream from the right ventricle is the peripheral vasculature, and specifically the peripheral venous system. So we end up having distension in the jugular veins, right? Because they fill into the vena cava. So we backflow fluid, out of the right ventricle, goes into the vena cava, the jugular veins, and then the peripheral veins. So they'll end up having edema, right? They'll end up having some ascites, and these other issues too. Now, importantly, left ventricular failure can cause right ventricular failure, right? Because if we end up losing the ability to pump blood efficiently out of the left ventricle, right? We said it's going to backflow into the pulmonary vasculature, right? Which is going to raise pulmonary pressures, which, again, as we said, the right ventricle does not accommodate well to changes in pulmonary artery pressure. So if that happens, we can end up developing right ventricular failure too. We can have biventricular failure. And that's usually the most common cause, one of the more common causes of right ventricular failure. And same likewise, if we lose right ventricular function, right, which again pumps blood through the lungs into the heart, if we lose the ability to pump blood through the lungs to fill the left ventricles, we're going to have impaired pumping performance as well. So there, it's tempting sometimes to look at these things as isolated, silos, right? Right ventricular failure, left ventricular. Usually you're going to affect both, right? Your body's really more of an ecosystem, in really more than anything, right? So left ventricular failure has some very notable signs, right ventricular failure as well. But again, left ventricular failure, if we have backflow of fluid into the lungs and we raise pulmonary pressures, that's going to cause right ventricular failure as well. And right ventricular failure, if we can't get blood into the left side, right, from the right side, from pumping through the lungs and returning into the ventricles on the left side, that's going to impair pumping performance on the left side as well. So they work, they can affect each other. Okay. Now, another classification, so we talked about sides, we talked about types. A more common definition that we see utilized now is by ejection fraction classification. So in this, again, remembering normal ejection fraction is between 55 to 75%, right? That's normal, right? We don't pump everything out at every single beat. There's always some remaining, but it's about 55 to 75%, ejection fraction. Now, heart failure with reduced ejection fraction, which we used to call systolic heart failure, you may still see it referred to as that, but we're seeing this definition used more often, where the ejection fraction is below 40% or lower, right? We call that HREF, or heart failure reduced ejection fraction, okay? And then there is heart failure with preserved ejection fraction. This is what we used to call diastolic heart failure, which we just talked about. So HPEF, heart failure, preserved ejection fraction. And these are patients where the ejection fraction may be a little less than normal, but it's not super low, right? It's preserved for the most part. It's above 50%. Okay, we said normal is about 55 to 75. Because again, heart failure can either be reduced pumping performance or elevated filling pressures or impaired relaxation, and this is what that is, that HPEF, right? So, or diastolic heart failure. Okay. The problem with this, diastolic heart failure does not have as many direct therapies as systolic heart failure, because we're dealing with more like the relaxation. We don't really have drugs to do that, but we're developing some therapies now. And then there's heart failure borderline. These are patients that are kind of between HREF, HPEF, right? They appear more similar typically to HPEF. And then there are patients or HPEF improved, patients who had reduced ejection fraction. They were given a therapy, often resynchronization therapy, to kind of get the hearts to beat a little bit more in a coordinated fashion. And their heart failure improves above 40%, but they still have clinical heart failure. So again, HREF, less than or equal to 40% ejection fraction, talking about the left ventricle primarily. And then preserved are patients with an ejection fraction greater than 50%, but they still had syndromatic heart failure because they had that impaired diastolic function, impaired relaxation. Then there's the borderline patients who typically resemble more of that HPEF clinical presentation, and then HPEF improved. Now, again, just remembering, we talked about this earlier, that it's not all about ejection fraction, especially in patients with heart failure, right? I've seen patients with very severe, or very impaired ejection fractions, and they were both, like the patient with the lower ejection fraction. I'll never forget this guy, had 17% ejection fraction, and had a much better 6-minute walk test than a patient I saw that same day in the 30s. So it's, again, it's not just what happens at ejection fraction. We're even looking at now that ejection fraction may not be the only, value from an echocardiogram or cardiac cath that matters. There's maybe other things going on in the heart too that may be more sensitive to some of these changes. But either way, another way that we look at the heart, our patients with heart failure, or rather functional classification. So the key thing to bear in mind, NYHA classifications, New York Heart Association classifications, these are all patients with heart failure. So all of them have it, but we're classify them by their functional ability, right? So not just by ejection fraction, right? So they have either, HPEF, HREF, but their functional classification. So class 1 is they have heart failure, but they don't have any limitations in physical activity, right? Ordinary activity does not cause undue fatigue, palpitations, or shortness of breath. So they can do most things without really many issues. And then there are class 2, where we see a slight limitation in activity. They're still comfortable at rest, no symptoms at rest. Ordinary activity does result in physical activity, right? So we start seeing some limitations, right, from ordinary activity. And then there are class 3 patients with our NYHA classifications, where they have a significant limitation in activity. They're still comfortable at rest, but now less than ordinary activity causes fatigue. And then there's class 4, right, where they are symptomatic at rest. Any level of activity, even like putting on clothes, can cause discomfort. They can't do any activity without discomfort. Nothing, right? So class 1, they still have heart failure. They're living with it, but they don't have any limitations, really. Like they can do most typical activities without having symptoms. Obviously, there's a limit to that, but typical activities, 7 METs or above, usually they're okay. And then class 2, right? These are patients that can do activity, but they have some limitations, still comfortable at rest. They get symptoms from ordinary activity, though. And then class 3 would be less than ordinary. They have symptoms. And there's a great way to kind of conceptualize this. Go to this figure here. We look at functional class by MET, right? So class 1 would be anyone with 7 METs or above, right? Class 2 would be anyone between 6 and 5 to 6 METs. Class 3 would be anyone 2 to 4 METs. And then class 4 would be just 1 MET capacity. Now, it's a key thing to remember that most activities of daily living are about 5 METs, right? And probably the most exerting thing that you'll do is climbing a flight of stairs. There's about 5 METs, climbing them vigorously. So if you're class 1 heart failure, right, you still have enough cash in the bank to do that normal activity without getting many symptoms, right? Because you've got 7 METs to spare, right? And we're demanding at most 5, right? So you might, you're able to do it because you got a little bit of reserve. Now, class 2, right, we said for class 2 patients, slight limitation, comfortable at rest. So again, we'll say this is 7 or above. This is 5 to 6 METs. This is 2 to 4. And this is a 1 MET capacity, roughly. These are all estimates, but pretty good general rule of thumb. So most ADLs, again, are 5 METs for activities of daily living. So someone with class 2 can still do most ADLs, but even ordinary ADLs are going to cause some limitation because they're getting pretty close to 100%, roughly, of their peak capacity, even from basic stuff. But they can still do it. They've got enough cash in the bank, but they're living pretty close to their margins. Class 4, right, significant limitations, right? Still comfortable at rest because to live, it costs about 1 MET, right? It costs about 1 MET to live, to fuel our body, keep the engine going. But less than ordinary. Again, remembering ADLs are 5. If they've only got 4 in the bank, they're running at a deficit, right? So they can't do normal activity. Less than ordinary activity causes limitations, causes symptoms, fatigue, dyspnea, or they are unable to do it. Stair climbing is a pretty good general rule of thumb. If you can climb a flight of stairs without symptoms and like really climb them, you're probably class 2 or above. And class 4, again, we said METs, right? The MET to live is about 1 MET. It costs about 1 MET to just live. And they are at a 1 MET capacity. So even just living, sitting is going to cause them symptoms. And doing anything is going to cause distress because we're now operating at a deficit. We're beyond our margins, right? So again, class 1, they've got 7 MET capacity or higher. No limitations because they've got enough cash in the bank. They have enough reserves. Class 2, we're pretty close to our margins because we're at a 5 to 6 MET capacity. And most ADLs, right, go up to about 5 METs. So they may get some symptoms, some limitations because we're getting pretty close to our margins. Class 3, we're at a 2 to 4 MET capacity, and even basic stuff at 5 ADLs we may not be able to do, or you're going to have serious symptoms because we're beyond our margins, right? Because again, ADLs cost about 5. We only got 4, we're going to have some problems. We're running at a deficit. And then class 1 through 3, they're all above 1 MET, so they don't have any symptoms at rest because they have enough at least to sit and be alive. Class 4, because they're at a 1 MET capacity, even just sitting, right? Even just resting, living, which costs 1 MET, they're going to have symptoms because their peak capacity is 1 MET, right? So a nice way to conceptualize it. And again, we also have the AHA, American Cardiology and American Heart Association guidelines, looking at risk factors and then in other different stages, A through D. We have here stage A, which are patients at risk, right? These are patients with your risk factors or taking different drugs or other issues here who don't have heart failure, but they're at risk for it. And they may develop, a structural heart disease or have some sort of event, right? So they could end up having an MI. And again, we want to intervene here, right? Primary prevention. And then if we get, beyond that point, well, then we're in secondary prevention. We want to prevent them from developing heart failure. So that's getting them on medications, so lifestyle changes, cardiac rehab, other different things here. However, if we don't address these things here and they move to stage C, we can end up having heart failure. And again, structural changes, and then those different types of symptoms that manifest. So that's our classifications that you might see in a chart. And again, I also want to stress that heart failure really, it's a syndrome, right? It's a syndrome of, sorry about that. It's a syndrome because we have acute and chronic, right? So acute heart failure is, immediately occurring, right? It's something that, it's a medical emergency, could result from maybe acute pulmonary edema, where we got really bad swelling of the lungs, acute myocardial ischemia, like a heart attack. It's kind of the end sequelae of a heart attack. You get it, you've got an infarction, you have that myocardial stunning, where the myocardial is almost in that rigor mortis. It doesn't contract, and we're losing pumping performance as myocardial cells begin to die, or just lose their ability to, we're not perfusing them. And then there's that chronic, which is kind of what we've been talking about for the entire lecture, that compensated failure we've made as adaptations. There's poor pump quality, there's all those changes, but it's a chronic state, chronic syndrome, okay? And, it's important to know that patients with with chronic heart failure can go into acute heart failure, right? They can switch into that balance, right? And we'll show you this kind of cycle that can happen with these patients. Now, again, acute versus chronic. Again, acute, the time course is sudden, it's instant, it's over over a couple hours to days. Chronic, it's that progressive, the chronic nature. And again, most often causes of acute heart failure, you have an MI or pulmonary embolism, right? Something that acutely disrupts myocardial pumping performance or filling pressures, or vascular resistance, like severe malignant hypertension can cause acute heart failure. The problem with this, you don't have time to compensate. All those compensatory mechanisms that happen from the kidneys, while they are emergent, right? Like they do help preserve us. Like we don't have enough time to preserve and keep ourselves alive. Right? If you have a heart attack, for example, or pulmonary edema, you might not survive it. You're going to go into heart failure, but we may not have time to compensate it to keep you preserved. And then chronic, again, we had that full compensation. There's chronic edema, chronic congestion, but they're relatively stable. But the problem is patients can with chronic heart failure, can have a sudden deterioration and go into acute heart failure, which we would call acute on chronic heart failure. This often happens, again, we said patients are in that precarious balance between compensated and decompensated, right? Where those neurohormonal factors are, should be in balance, they can suddenly become out of balance, right? Maybe they have, an acute illness, or what happens often around the holiday season, Easter, Thanksgiving, patients eat a diet that is high in salt, and they hold on to more fluid than they're supposed to be holding on to. Preload gets really high, we are flooding a failed heart, they go into acute decompensation, and then they have, acute changes on top of a chronic heart failure. So acute failure on top of a chronic failure. The problem is, every time you decompensate with heart failure, your recovery may not be full, right? It's going to be maybe an incomplete or partial recovery, or you're going to have a little bit of a lasting impact on that patient's status. So our goal for patients with heart failure is when they're compensated to keep them compensated, right? Because again, when they have that first, they have acute failure, they can leave, they'll recover, go back to the chronic failure, but they leave a little bit behind. So the more the compensations they have, the worse their prognosis is. And there's some data on the first annual decompensation by age, and obviously gets higher when people get older. So if you're working with geriatric populations, you really need to be cognizant of these things. Now, when we're assessing patients with heart failure, we'll look at several things: chest X-ray to look at fluid status, the ECG. They may have a wider QRS complexes, certain dysrhythmias. The echocardiogram, right? We're going to look at the left ventricular size. We're going to look at ejection fraction. We're going to look at wall motion, how well the heart's pumping. We're also going to assess the coronary arteries, right? They may often undergo a cardiac catheterization or cardiac cath to look at if there's underlying ischemia, which can make their prognosis a lot worse. Look at a PET scan to see how well they're perfusing, maybe even a cardiac MRI. The other big things, we'll do general chemistry labs, and we'll look at BNP. And I have this highlighted, right? Because brain natriuretic peptide, again, is released from the ventricles under stretch or under strain. Now, typically, we should have, this should not ever really be elevated in anyone in normal settings. Less than 100 picograms should be close to zero for most people. Patients with heart failure, because ventricles are under stretch, will be elevated, but it should be less than 100. And every increase above 100 is an increased risk of mortality. So the more the heart stretches, the more BMP releases and the worse the prognosis is. There's other cutoffs. Every facility is a little bit different. Every lab is a little bit different. And the levels for cutoffs are according to, a few different things. Age is a big one. So we're saying really if anyone's got a BMP above 100, right, it's pretty sensitive for acute heart failure. And again, anything higher, the higher it goes, the worse the prognosis. And then you may also see pro BNP, which is like a precursor to that. And generally that, we say a pro BNP less than or over 300 would reflect an acute heart failure. So BNP, we look at this to assess severity and stability. And even patients with heart failure, it should still be below 100. And every time it increases, their risk of mortality goes up. But again, it's going to be dependent on the patient and their age as well. There's different cutoff points for patients under 50, 50 to 75, and over 75. So just bear that in mind. When we look at the jugular veins as well, we'll assess these too. So again, in patients with heart failure, we'll see, especially right heart failure, but again, left heart failure can cause this too. If there's backflow, enough from the left side backing into the lungs and then affecting the right side, we can end up seeing this distension of the jugular veins as they spill out into the periphery. And then this is how we assess. So we'll learn how to do this in labs. So I'm not going to cover this too much, but normal JVD or jugular vein height should be 4 centimeters or less if we measure it from the sternal angle of Louis. And then an important thing to bear in mind is fluid status when we're doing our medical exams. So we want patients to remain stable, right? We want their fluid status to remain stable because if we have too much preload, too much blood volume, that's going to affect the ability for the heart to pump. We want to maintain, volume at a very consistent level. Any patient that demonstrates a high or a rapid increase in weight and swelling indicates that something's going wrong here, right? They're retaining fluid. General rule of thumb is someone gains more than 3 pounds overnight or more than 5 pounds over a week, and it's notably for someone, especially with someone at risk or who has heart failure, and that they're reporting less voiding or less urination. And quite often these patients are on diuretics, so they're often urinating often, like very frequently. So when someone's gaining weight, voiding less, swelling, that means that they're not, their body's holding on to more water, right? Because normally we excrete volume through urination. If you're urinating less and gaining weight, you're holding on to the volume, right? The kidneys aren't passing that fluid out. So we want to check for the fluid status by, we want to maybe sending them into the emergency room to get some of that fluid taken off. A common sign that patients will report is that they have this progressive orthopnea. Now, again, quite often patients with heart failure have orthopnea. They can't lay flat. So they have to sleep propped up with maybe a couple pillows. Now, if anyone with heart failure ever reports, really anyone, reports that, hey, I was able to sleep comfortably propped up with 2 pillows, but now I need 4 pillows to stay comfortable, that's also a precursor that they're holding on the fluid and are approaching a period of maybe that acute heart failure or acute decompensation. And again, this happens so often around the holiday season because people eat these very salty dishes, hams, turkeys, stuff like that. So being able to be cognizant of these things as well as educate patients to avoid maybe eating some of those things, really important. But being able to detect these changes, right? This retaining of fluid, in concert with less urination, really important. So if someone ever mentions this, patients usually weigh themselves every day, ask them this question, and then do further follow up with your examination and maybe referral out. And again, this is what we may end up seeing is with someone with congestion, they'll have this backflow of fluid into the lungs. So, we'll spend a little bit of time talking about the medical management of heart failure. So We're going to get on to more of these later, even in this lecture for exercise. We covered some of the pharmacology already, and then surgical management we'll cover later on, heart transplant and LVADs. But the general goal for pharmacotherapy for patients with heart failure, we want to reduce afterload, so they'll be given an ACE inhibitor. We want to attenuate the sympathetic nervous system outflow, so we'll be given a beta blocker to kind of balance that out a little bit. We also think that helps slow the heart down a little bit to allow it to contract. It's kind of that length, that speed, force, or velocity of force curve. If we allow the muscle to pump a little bit slower, we can think it can produce a little bit stronger contraction to get more blood out. So that's where we see beta blockers. It's a little counterintuitive because it does block some of those compensatory mechanisms. But the way to view it is we bring this kind of back into balance. It's also an antiarrhythmic. Diuretics, we're going to give them things to reduce blood volume. So you'll see that given to patients will be on Lasix or aldosterone. And then you may see digoxin used. That's very rarely used now. This is typically used in more acute stages. These phosphodiesterase inhibitors or positive inotropes to help the heart improve its contractility is used more in acute settings. Your ACE inhibitors, beta blockers, and diuretics. That's probably your biggest, the three primary medications used to treat heart failure. And then if it gets really severe, patients may often be given a ventricular assist device like an LVAD or an RVAD or a BiVAD. These used to be short-term solutions. Now they're kind of long-term solutions. And we'll talk more about that in our heart transplant lecture. We'll get more into that later. So that concludes the classifications and medical assessment of heart failure. And next we'll get into some of the rehab considerations and exercise testing for heart failure.